My name is Janaína Koenen. I'm a doctor, I'm an endocrinologist, and this is a podcast in which we talk about metabolism, lifestyle, diseases, health, behaviors, and today I have the honor of having a guest here. You'll never guess. So, Dr. Ahmed El Saka is a friend, is a mentor. It's someone I actually pursued. I went to another country to meet. Thank God. And I learned so much from him. And today I can say we are really good friends. So welcome. I'm very happy you're here in Brazil.
Thank you, Janaína. Welcome to you. And I'm very happy that you invited me to this beautiful podcast.
So let's tell my followers.
Okay.
Let's tell people about you, about yourself, because I don't think people really know all you went through and all the studying you had to go through to be today in this position, which we'll say in the end. So tell us everything you did, like in the medical field.
In the medical field. Okay. I'm a medical doctor. I graduated in 2007 from the School of Medicine, Alexandria University in Egypt. I was a regular medical student. Then I had my residency in neurosurgery. My father always was dreaming that I will be a neurosurgeon. So actually, it came like this. I take the residency of neurosurgery and I like it at that time. I spent 5 years in neurosurgery field. I was good at that time, by the way. And then I was concerning about the glioma patient and GBM patient and cancer patient. However, the side effect coming out of surgery, quality of life of the patient after surgery, always give me this alert that this is not the right thing that we do right now. Or maybe there is something else need to be added to the standard of care to improve it. Especially the epilepsy. Epilepsy was terrible. When you look at the time to the patient who have this kind of continuous refractory epilepsy or epileptic seizures, it's look like a kind of something abnormal with him. So this take my attention that maybe there is something to treat these patients by other way other than epileptic surgery or anti-epileptic drug, because it actually in 65% of post-surgical patient it didn't work. It's a refractory epilepsy. Refractory epilepsy, by the way, means that this epilepsy is not improving by two different kind of anti-epileptic drug with maximum tolerated dose. So I started just to have a regular Google search about refractory epilepsy and what is the other solution other than refractory epilepsy. At that time, I'm not aware that I'm thinking about the integrative part of the medicine. And I'm thinking about to have another option other than the standard of care. Because actually, this is a definition of the integrative oncology and the standard of care. Standard of care is not solving the problem, and you're searching about other things that can solve the problem with the evidence base at the same time, of course. So I found that Epilepsy Foundation, and it talk about the ketogenic diet therapy. And it take my attention that only change in the diet composition can cure the patient from epilepsy. Is that possible? So let's try it. I had a patient at that time. She had a severe refractory partial epilepsy 24/7. She didn't stop. To the limit, they put her under sedations for 24/7.
Before surgery or after?
After surgery.
So you did epilepsy surgery and then she...
No, it's not an epileptic surgery. She had a glioma, a low-grade glioma. And we perform a surgery for her. And one of the complications, post-surgical complication, is the epilepsy itself. So this patient, I never forget in my life. Okay, she was a girl, 17 years old, called Hannah. I never forgive her. So it was a changing to my life. When I searched about the answer for refractory epilepsy, I found the ketogenic diet. Next day, I read a lot about the ketogenic diet, and I know it's so sophisticated and complicated, but I tried to make it simple. I put the patient on fasting for 24 hours. And when I gave her some food, I gave her only soup, I gave her only protein or only fats meal, but I never gave her a carbohydrate. I know this is not the typical ketogenic diet, but at least for her case, it worked very well. Very well. And her epilepsy stopped. And when she started to eat normal again, eat a carbohydrate, her epilepsy started again. So actually, it blew my mind. And I take the decision, long story in short, I take the decision that I will study more about the ketogenic diet in epilepsy. I traveled to the United States. I went to Johns Hopkins hospitals. I attached it to a program called Overseas Training Program for Neuro-metabolism. At that time, it was focusing only for ketogenic diet and epilepsy. So I finished it and then thinking about to integrate this with the standard of care. But unfortunately, all the standard of care doctor, all my friends, all my mentors in the neurosurgery was refusing me, was closing the door in front of me. Okay, they can't accept, okay, how can I say to the patient, do not eat bread, do not eat pasta. Is that possible? Are you crazy? So actually, I didn't give up and I quit the neurosurgery at the end and I changed my career from a neurosurgery to neuro-metabolism. I have my personal experience, I will not say it today, but it's a very sad story about me, about my mom, that helped me actually a lot to take these tough decisions, because to shift from surgery to non-surgical specialty is very hard, by the way. So I had my own reasons, so I changed my career from neurosurgery to neurometabolism. Study more and more about the neurometabolism, about biochemistry.
You went to Harvard and you did a clinical applied biochemistry, right?
Yes, actually, yes. I didn't want physically, but it was like an online program called the Clinical Applied Biochemistry. I take it the course, I take my exam, I succeed in that, and it was very essential to understand the metabolism and understand the neurometabolism at that time. So when I take the Clinical Applied Biochemistry, it's opened my mind for a lot of metabolic pathway and chemical pathway and what's meaning by metabolism, how we can gonna to treat diseases. So I have the decision, I will not only be a neuro-metabolism specialist, I will be a general metabolism specialist, not only treating the neurological patient from a metabolic point of view, but also cancer patients, also metabolic or cardiovascular patients. Alzheimer's, neurodegenerative disorders, yes, mitochondrial disorders, fibromyalgia, rheumatoid arthritis, autoimmune disorders. There is, you know what? Every single disease have a metabolic aspect. Metabolism, I consider metabolism is not a specific or a specialty. It's not an immunology, it's not a rheumatology, it's not a surgery. Metabolism is one of the basic.
It's medicine, right?
Exactly.
It's something we forgot.
One of the basic of the pathology and of the physiology. And you need to correct it to restore the physiology, and you need to look at it to understand the pathology of the disease. In every single disease.
There's always something we can do if we look from the metabolic point of view, right?
Yes, of course. Of course.
Yeah. So, and you did also genetics and epigenetics.
Yeah, because actually there is a connection between the metabolism, metabolic pathway, and genetic. And actually this is one amazing thing. We are thinking before that genetic is what made us like this today. So everything is genetics. Diabetes is a genetics. Cancer is a genetics. And everything is genetics. My gene is my destiny. And actually we found no. There is a huge difference between the genotype and the phenotype, which means there's a huge difference that you have a bad gene and you express this bad gene. I may have a bad gene, but it didn't express. My body is able to silencing it. And this field called epigenetic. Epi means above, genetics, the DNA. So some group, metabolic group, can be above the gene and change its expression, not its sequencing. Okay, so I study the genetic, epigenetic, and gene expression because of that part, because it's a part from the metabolic disorder.
Yeah, and this is also, guys, all the population, the world's population, is sicker and sicker and sicker. Why? Because of lifestyle. And lifestyle, it's all connected to metabolism, which is connected to epigenetics. So if we don't start looking at our lifestyle and the things we're doing, the things we're eating, the things we're thinking, hardly we're going to beat these diseases, right? I mean, nothing's going to change.
Exactly. Don't blame your gene.
Don't blame your genes. And you were a fellow researcher in Thomas Seyfried's lab too, right?
Yeah.
When was that?
Again, it's 1 year I finished something and I found that I need to know more about something else. So when I finished the clinical blood biochemistry, when I finished from neuro-metabolism and general metabolism, I went to the cancer. And cancer metabolism, it's beautiful. It's beautiful. Okay. And it explains a lot of things. It's answer a million of questions that didn't answer by standard of care. And when you study the cancer metabolism, you cry. You cry because how this science is already exist and proved and have its high evidence. And the standard of care oncologists didn't know about this. They didn't put into the considerations. You know that you can change your simple metabolic reprogramming before the radiotherapy that increase the chance of radiotherapy, like 75% more chance to succeed the radiotherapy. And I mentioned the radiotherapy specifically because radiotherapy is just one chance. You cannot radiate on the same place twice. So before you got this one chance, make sure that you make it right. So when I studied the cancer metabolism, okay, I was diving more and more to the cancer metabolism. And there is a beautiful book called Cancer as a Metabolic Disease.
Thomas Seyfried's book.
Yes. Thomas Seyfried is my dad, is my godfather. He is my friend. I own these guys my life. He is my mentors. He is my everything, to be honest. If I thank him from here to tomorrow, I'll never give him his credit. Anyway, I met Thomas Seyfried in 2016 in Florida. It was a Metabolic Health Summit. It was the beginning of the Metabolic Health Summit ever. And I had these posters of GBM patients I treated successfully with preoperative, intraoperative, and postoperative metabolic reprogramming. And it was the first time in the world that anybody tried the ketogenic diet therapy and ketogenic metabolic therapy, even before the surgery and during the surgery and after the surgery. So the patient was more than 24 months survival, which is unique in GBM, which maximum 9 months survival with the best of the standard of care. So I meet Professor Thomas Seyfried at that time, and when I see him personally, oh my God, my tongue was like, I can't even express. So when I start to talk with him and I told him I have a GBM patient, can you look at my poster? He said, okay, no problem, go to me. I show him my posters. He was fascinating about the work I did. And then he offered me a job as a research fellow in his lab. It was an amazing time. It was from 2016 to 2017. Unfortunately, due to a lot of stuff that forced me to go back to Egypt in 2017 and start my career back in Egypt again.
So that you know, the same paper, this poster he took to the summit was the one that made me go from Brazil to the Metabolic Health Summit in 2020, I think, right? Because
yeah, I remember that.
Yeah, my father had cancer, so I had my own story with this, and I didn't have any information. So after a while searching, a long while, and I found his paper. So I said, my God, I have to talk to this guy. So I went there and I met him because of the same paper.
Yeah, I remember that day.
And in Egypt, you were a senior researcher from the Egypt
I
Foundation,
worked
right?
from 2017 or beginning of 2018 to the end of 2022 as a senior researcher in Egyptian Foundation for Cancer Metabolic Research. And actually in Egypt, I had an amazing time also dealing only with cancer at that foundation. But a lot of things I will not say invented, but I would say discovered during that period, like photodynamic therapy, sonodynamic therapy, ferroptosis, okay, specific mechanism of cell death. And also I had my own lab there that it was a drug delivery lab and nanoparticle formulations lab.
So this guy, he works during the day with patients and during the night in the lab.
Yeah.
So he's designing new drugs and special stuff. We'll talk about this in a while. But this is only that this guy I'm talking to has a lot of experience. And you did some formation also in oxytherapies, right? Like ozone, hyperbaric oxygen therapy, which is a part also of this kind of treatments, right?
To be honest, I'm very happy that you asked this question because it's very important to understand that diet is not the only part of the metabolic therapy. There is a lot of things with the metabolic therapy. Part of it is the oxytherapy. Okay, oxytherapy is very important. How to deliver oxygen into the cell and how this oxygen react inside the oxidation reduction process or the oxidation reductions chemical pathway inside the cell. Mitochondria is oxidations and mitochondria is life. So oxygen is life. So oxytherapy is a very important part of the metabolic treatment. I have a lot of things regarding the hyperbaric oxygen therapy, normobaric hyperoxia, ozone therapy. And by the way, photodynamic and pseudodynamic therapy considered a part of oxytherapy.
So why, everyone knows I already talk about this a lot, but I want him to answer this question because I think everyone should answer this question to me when they come here. Is why a metabolic approach? Why not only the standard of care? Because most of the oncologists, they keep telling my patients, why are you doing this? Why there's no evidence? I said, what? So why a metabolic approach?
Actually, it's a very hard question with a very simple answer. Why a metabolic approach? Because the standard of care failed to succeed alone in a lot of cases. Okay, I will not say in all the cases, but in the most majority of the cases, especially in the cancer, standard of care, yes, it helped, but it didn't help alone.
Especially in grade 3 and 4 stages.
Exactly.
3 and 4
so
cancers.
At that time, again, back 30 minutes when I told you about the epilepsy thing and glioma and surgery, this is the answer. When the standard of care failed to do something and there is no solutions, we need to search about other alternative in medicine with evidence base. If you found this alternative, this is an integrative part of the medicine, which from its name, integrative, need to be integrated with the standard of care. By the way, standard of care is the protocols, right? It's one thing fit all, almost. It's depending on the type of the tumor, not the type of the human.
Yeah.
However, the integrative medicine or the metabolic medicine as a part of the integrative medicine is looking to the humans more than the type of the disease, right? So why metabolic? Because metabolic is looking at you as a human, not at the disease itself. And its answer, again, million of questions, the standard of care is failed to answer it.
And another point is that there is evidence, right? So I'd like to talk about, is there, what kind of evidence do we have today that a metabolic approach could work? Because when we say this, okay, they said, oh, integrative medicine, this is like alternative medicine. There's no evidence whatsoever. There's nothing on it. I said,
very good question,
guys, let's look at the literature, please. Let's go back and look.
Okay.
Because people are only reading guidelines, right?
Exactly. And you need to differentiate between the evidence and guideline. Evidence, it didn't mean the guideline, and guideline didn't mean the evidence. I give you an example. The guideline for nutrition, okay? It's being released by United States Agriculture's facility or institutes, okay? They release the guideline for nutrition, okay? They change it every 5 to 6 years. In 2016, they say that carbohydrate is good. Saturated fat is very bad. Non-saturated fat also is very bad. Take skimmed milk. Do not take more than 1 egg a week, right? This is a guideline in 2016. You know what happened? What happened is in 2020, after 4 years, okay, of this guideline, they found that a lot of patients suffering from diabetes after we applied this guideline. So they start to look again into the evidence. And again, evidence is something other than the guideline. And they found that actually carbohydrate is bad for diabetes and fat is good for the heart, especially the good quality fat. And they changed their own guideline. So guideline is not a Bible's book. It's changing according to the evidence. Okay, what about the evidence? Evidence is, there is something called the clinical based evidence. So I cannot do anything except it have a clinical based evidence. Clinical based evidence starting from highest ranking to lowest ranking. However, if you have observational phenomena on one patient, you publish it as a case study, right? Case study considered as a guide or as an evidence base. You know that the expert opinion is evidence base. So if somebody is expert in some field and he had an opinion, this is considered as the lowest class of evidence base.
And did you know that American Heart Association guidelines for heart disease and statins, and that 80% of their evidence it's expert opinion. Most of them are C or D.
Yes,
not
exactly,
A and B.
Exactly. So actually, there is a line, there is ranking for the evidence starting from the expert opinion up to clinical, randomized, blinded clinical study, right? So this is the highest one and this is the lowest one. I need to follow the evidence-based medicine, but there is no one tell you that you need to follow the highest rank of the evidence-based medicine. And you just give an example about the American Heart Associations. Most of them are depending on C and D evidence-based. What about the metabolic medicine? We had a lot of evidence, not only a cell cultures or a case study or case series, but also randomized trials till now. We had a very good evidence, and every year this evidence is growing up and up and up.
And why don't people talk about it in the medical field?
Because it is still not included in the guideline. And the doctors who need to search about any alternative, he will find it very easily with the evidence. However, the doctors who are sitting in their desk and they waiting for the guideline to come to them, they are still ignorant about them, about the integrative medicine, because it's not included yet in the guideline. But mark my word, after from 10 to 20 years from now, it will be among the guidelines. However, our patient, unfortunately, a lot of them didn't have 10 to 20 years to wait for this to be included in the guideline.
Yeah, that's true. And especially because if you see the drugs approved for cancer every year, I mean, the level of evidence for them to go to the market, it's very scarce. Actually, most of them don't have phase 3 clinical trials. They have this accelerated approval. And actually, even these new drugs don't have this whole evidence to support them. And
that's why there is a post-market research, and there is a lot of drugs that been withdrawing from the market after 5 and 10 years of its marketing, right?
Yeah. So I think things should be done differently. I think it's because there's lots of money involved in the drug industry too, and maybe it's easier for the drugs to. But it's true.
Yeah.
And if you
actually, it's true.
If you see the papers published in JAMA, they publish this paper showing that like 80% of the drugs they don't even have survival benefits. So it's only size or a bit of like 2 or 3 months without disease.
Come on, Avastin in GBM, temozolomide in GBM, it just add few months. Temozolomide just add 4 months to the standard of care. It's a very expensive drug. It had a lot of side effect. Avastin too, by the way.
If it had a good quality of life, it would be good, right? I mean,
yes.
4 months with my dad would be great. 4 months more.
Yes,
before
exactly.
he died. But that's not the case, right?
What about if you have something, okay, maybe more safer and more effective in the same time?
Yeah, that's perfect.
It would be great, right?
Yeah, and we do have.
Actually, we do have, but unfortunately, we don't have the opportunity to include this in a clinical trial. Clinical trials need a ton of millions of dollars.
Yeah.
You know that.
And no patent, no clinical trial.
No patent, no clinical trials.
Yeah. So guys, don't get depressed. Let's move on. So So we need a metabolic approach because it works, right? And it's an option. So when we talk about metabolism, are we talking here only about diets, or because oncologists, there's two questions in the same question, okay? So this is one question. And the second thing is it's very common for an oncologist to tell a patient, eat whatever you like as long as you don't lose weight. So I'd like you to comment on that. And also if this is the only thing that matters, or if there are other things that we should take into consideration when we talk about metabolism.
So first of all, we need to differentiate between nutrition and metabolism, okay? Because metabolism, and by the way, they are not apart from each other, okay? Nutrition is a part of metabolism, but metabolism is much more bigger. So is the diet the only thing in the metabolism? No. What's meaning by metabolic therapy? Metabolic therapy is a bunch of metabolic pathway that in physiology, in the normal, okay, it having some rate of expressions, and in disease, either it's upregulated or downregulated, okay? So our rule is to correct this metabolic pathway from the pathology side to the physiology side, okay? So this bunch of metabolic pathway can be corrected with diet, like carbohydrate metabolism pathway. If you have a high lactate dehydrogenase enzyme, high G6PD, a lot of things can be corrected with diets. Ketogenic diet, low methionine diet, any kind of diet. Phenylketonuria, people with phenylketonuria, the treatment or diet. Diet is a part of metabolism, but a lot of metabolic pathway cannot be corrected only by diets. It needs supplement, labor drugs, as you mentioned before, sessions like hyperbaric oxygen therapy, and any oxytherapy. So diet is a part of metabolism, but metabolism is much more bigger. This is number one. Number two, regarding the oncologists who say eat whatever you want without losing weight, actually the guideline came from nutritional standard of care in cancer. They say something different. They say be lean as much as you can without being underweight. This is the number one recommendation, nutritional recommendation in every single type of cancers. Be lean as much as you can. So be on the low normal range of weight as much as you can without being underweight. Not eat what you want without losing weight. No, lose weight if you are obese. Lose weight if you are overweight. And by the way, even if it's not improving the metabolic pathway, it will improve the standard of care side effect, because you know that chemotherapy is calculated according to the weight. So if I am 100 kilogram, I'm obese, morbid obese, and I got a cancer, and they will give me 5 fluorouracil, they will give me 5 milligram per kg, calculated, multiplied by 100, or multiplied by only 50 kilogram. You see, I can drop the side effect if I am in normal weight or in low normal weight. This is the number one recommendation.
Yeah, not here. I mean, usually what doctors say is eat as much as you want and don't lose weight. Once a patient of mine, we did a DEXA scan. He had a GBM. He was overweight. He was pre-diabetic, and he lost weight. And his DEXA scan was normal. He lost only fat, not lean mass. And the oncologist was very angry because he actually had to calculate again the dose. And he was changing this dose and he was losing weight. So, and I said, but his body fat percentage is 20%. For a man, that's okay. Like, he's not cachectic or anything. And actually, he improved his metabolic, his labs and everything. And he can't lose weight because he has to eat as much as he can, so he doesn't lose weight.
They are afraid from cachexia, but
cachexia, I mean,
again, cachexia is different thing.
It's different,
okay. And if you look to the word lean, be lean, which is be muscles without fats.
And in breast cancer, if you're fat, you have a worse prognosis. You have a worse response to radio, worse response to chemo, worse cicatrization of post-surgery, more thromboembolic events, more recurrence. So it's good if you lose weight, fat. If you lose fat, the thing is, I think these studies in which mortality increased when you lost a lot of weight, I think they didn't correct it for lean mass. It's all BMI, and we know for a fact that BMI is not the best calculation to be done. These patients should be evaluated with DEXA scans.
I told you about the trials that they did on mice. They choose only the female mice in that trial, and they found that it was conducted about the ketogenic diet and cachexia, and they found that the ketogenic diet may induce cachexia, and actually the rat died not from the cancer but from the cachexia. And when this trial came and being published, a lot of people was terrified. Oh my God, we're using ketogenic diet. Ketogenic diet is great. We're using ketogenic diet for cancers. Are we gonna die from cachexia? And if you look to the methodology of the study itself, we found that all the participant was a female, not a male rat, which known to have more cachexia than the female rat. And the kind of cancers he was looking at, it was interleukin 6 producing tumor, which known to have an inflammatory reactions in the body, inflammatory reaction on the liver. So the liver will not be able to utilize the ketone body as a source of energy. So yes, it's normally you conducted a wrong diets, a wrong persons. You're conducting everything wrong. So the result was a cachexia. It's not the normal thing.
And something else, in mice, usually when they say they're giving a ketogenic diet, they're not actually measuring the ketone bodies. And the diet, the ratio is not really ketogenic.
Yes.
And the fats they use are rich in omega-6.
Very bad fats.
Studies in mice regarding
including the
ketogenic
inflammation.
diet.
Yes, yes.
And besides of that, I mean, it's interesting that people are terrified because we have human studies, trials, the ketocomp trials, many kinds, different kinds of cancers, with the ketogenic diet, showing that the ketogenic diet prevented cachexia, actually.
Exactly.
And that if you compared patients who were on ketosis, measuring ketones, for sure they were on ketosis, versus the patients who were not doing a ketogenic diet and both in chemotherapy, the factor that most caused cachexia was chemotherapy. And the ketogenic diet was preventing cachexia. So in humans, we already have studies. No one reads the reason. I don't know why.
Why are you going to look back?
One study in mice, badly, like poorly done, is published.
Poorly conducted, yes.
Poorly
exactly.
conducted. And then people are like, wow, because they don't even read the human ones.
Yes,
we already have
yeah,
human studies, guys. You should look at them. But we know that a diet is not enough. So tell us, when you said supplements, okay, I'm gonna get into that a bit.
Okay.
So how do we decide? Because we have some people taking like 40 supplements a day. And I see my patients sometimes they can maintain this like for 1 month or two, but then they're like exhausted. And actually I did some work trying to reduce it. And I wanted to see your opinion on this. So do we have to block all possible pathways to have success, or can we individualize in each person? Is there other tests we could use to try to narrow down a little bit?
The lucky patients, who just exhausted, but unfortunately the unlucky patients having a drug interaction. You know that there is a wrong conceptions on the people. There is a misconception that supplement, if it's not work, it will not harm. No, supplement contain an active ingredient called phytochemicals. This active ingredient have metabolic rules. If you conduct it wrong, you may have harm. There is a drug interaction. Saint Joseph word. It's very have a drug interaction with almost 50% of all supplement and medication in the world, because it affects the liver metabolism. So you need to do this with specialists who is very talented with choosing the kind of supplement. We choose the kind of supplement is another questions.
Just something.
Sure.
This word is iperi for Brazilians who are watching here. It's ipericum perfuratum, which is used a lot for calming down. So you shouldn't use it with cancer because it interacts with many chemotherapeutical drugs and with supplements. So you see, people are choosing supplements randomly,
yes.
Not randomly. Like they say, okay, this is going to block this and that. Though I'm going to take all of this.
Again, who told you that you already have this pathway is upregulated or downregulated? Again, there is a huge difference between the genotype and the phenotype. When you know that breast cancer usually having the androgen receptor positive or progesterone receptor positive or mTOR inhibition or BIK3 phosphoinositide 3 kinase overexpression, this is the genotype. Most probably the gene of the cancer of breast cancers is doing this kind of metabolic pathway, but there is a phenotype. It differentiates from patient to patient, even from a part of the tumor to the same patient, other part of the tumor. So there is exogenous or heterozygous response or heterozygous metabolic affection in your body. You need to have your own investigation or screening. We called it metabolomics. Metabolomics is like blood investigation that give you a metabolic intermediate inside a specific metabolic pathway, which for an expert in metabolism, he will know that this intermediate, if it's increased or decreased, it will reflect a specific pathway. Give you an example. If we look into melavonate pathway, okay, melavonate pathway is the pathway for cholesterol biosynthesis and coenzyme Q10 biosynthesis, right? Right. So if you need to look at the melavonate pathway and you need to take statin to block the melavonate pathway, hold on a second. Who told you that the kind of cancer you had or the kind of epigenetic you had right now is overexpress the melavonate pathway? Maybe, okay? Melavonate pathway is normal. So you have a test first, like cholesterol, total cholesterol test, or more specifically, if you can measure coenzyme Q10 in a plasma organic acid in urine. So this is called metabolomics. If I did the test and I know that this metabolic pathway is overexpressed or underexpressed, now you need to choose whether to block it by this supplement or by this supplement according to side effects. Of course, if we have a supplement that's safe without side effect, it will be better than off-label drug, even if it's safe, but it will still have a side effect. But there is a lot of criteria to choose a supplement. Not only that the supplement is known to block this metabolic pathway, because question number 2, who told you that this supplement is effective in blocking this metabolic pathway? You will say literature, right? I read in the literature that hydroxycitric acid can block melavonate pathway, right? Okay. This study you read about it, maybe it done on animals, maybe it done on cell cultures, and there is a huge difference between the efficacy in the cell culture and animal study and in vivo or in human study. Not because the drug is not effective. Yes, the drug can prove its metabolic pathway from cell cultures. But when I take the drug, you take it orally, okay? But in animal models, they intraperitoneal injected or intravenous injected. It's completely different route of administrations. When you take the drug, you take it orally. But in cell culture, they just put the drug inside the cell. So it's effective. And that explains why a lot of cell culture trials showing a promising effect with some phytochemical. Actually, we give this phytochemical to people with no effect. Give another example. You know that curcumin is almost blocking every metabolic pathway in cancer. It's great. If you add curcumin to the cell culture inside the cell itself, and you look to the cell, no matter what the kind of tumor, no matter what the kind of phenotype or genotype he had, he will die immediately. We give curcumin for patient every day. What's happened?
Yeah, but we have randomized clinical trials and meta-analysis showing for curcumin.
Yes.
In higher dose, right? For humans, showing good effect in humans.
Yes, but not as good as in cell culture or animal models.
Of course, because of bioavailability.
You answer the question, honey. Congratulations. Bioavailability and pharmacokinetics.
Yeah.
There is two different things, pharmacodynamics and pharmacokinetics. How I absorb the drug and how I react and metabolize this drug till it do its metabolic pathway inside the cell. Very quick. When you consume the active ingredients like curcumin, or you consume turmeric that contain curcumins. Actually,
it's like 5% curcumin, and it doesn't even get absorbed, right?
Yeah, exactly. This is the thing. If you buy a turmeric from online drug supplement, okay, a supplement company, online supplement company, you know that the best turmeric online. I'm not talking about the specific formulation that's made for research or made in compounding pharmacy. I say the people usually buy the
the
supplement from the internet. The best curcumin in the internet, is turmeric, containing 10% curcumins, which means if you consume 100 milligram, you're only taking 10% of this 100 milligram, which is 10 milligram of the curcumin, very low dose. And even this 10 milligram of the curcumin will not absorb it. It's because it's water insoluble. And the absorption rate of the curcumin is less than 0.1%. So actually, when you take these capsules that containing 1 gram of turmeric, you got 100 milligram of curcumin, and you absorb from this 100 milligram of curcumin, 1 milligram of curcumin.
Resveratrol is the same. It's 1% oral bioavailability.
Believe me, 95% of the phytochemicals coming from supplement is effective in cell culture, not effective in the human because of this. 95% of them, either they have a problem in the bioavailability, the absorption rate, or they go to the liver and being distracted, which called first pass metabolism. So they pass to the liver and liver changed its formula. So you need to bypass this thanks to the nanotechnology. Nanotechnology solve all of this problem actually.
So when we talk about supplements then, I like to what's the favorite supplement? What's the best supplement there is? So you said something here, which is the supplement that's best studied in humans. So for example, when you do studies in cell cultures, they simply neglect the microenvironment, the tumor microenvironment.
Exactly.
And we know as a fact that 50% of the tumor mass is macrophages from the patient. So it's like the tumor is not only tumor cells, it's everything around it, and it's a mass full of immune system, immune cells and other players, right? So you can't study cancer in cell cultures. You have to begin somewhere, but you have to take it to the second.
Cell culture is a phase.
It's a phase.
Just a phase.
You have just to upgrade.
And I give you a guide for this. If you found a very good result in cell culture and this result is bad on animal trial on the mouse, this is mean the microenvironment stuff. It's actually act on the cell, however the microenvironment is bad. Because usually they didn't give the supplement to the mouse by feeding them the supplement. They intraperitoneal injects or intravenous inject. If you found a supplement that working very good in cell culture and working very good in animal and not working in the human, so it's not a problem of the microenvironment, it's a problem of the route of administration, of absorption, or pharmacokinetics or pharmacodynamic. When I give it IV, I bypass the first pass metabolism, which is the liver. When I give it orally, it's going to the liver, most of them will be destroyed. Or even some supplement and drug, you know that off-label drugs like sulfasalazine, like mebendazole. Oh my God, a lot of people is knowing that mebendazole, is one of the off-label drugs that use in cancer, right? None of mebendazole absorbed outside colon. That's why it's antihelminthisis. It's made to remove the infection from the colon. Like sulfasalazine, it's made to treat the autoimmune reaction of the colon, like autoimmune colitis. So it didn't absorb outside the colon. If you needed to take it for liver cancers or for brain cancers, oh my God, it will not absorb outside the colon.
Some of it is absorbed, but you have to use very high doses. So for children,
this high dose will cause side effects, severe side effects. Like mebendazole, they're giving in one clinical trial, they're giving a very high dose of mebendazole for a patient. I can't remember the kind of cancer. Unfortunately, they found that all the patients having this high dose, it was a dose escalating trials. They found all the patients with a very high dose, the effective dose, they had a problem with the liver because it's affect badly on the liver enzymes. So again, the solution is not increasing the dose.
It's improving the bioavailability.
Increasing the bioavailability and the pharmacokinetics.
Yeah. I think, and you say that many people know that mebendazole is used for cancer. Like, no, most of people don't know. We know. Oncologists don't, because they're like, you're giving warm medication from oncological patients. Yes, we have phase 3 clinical trials with mebendazole for colon cancer.
Yeah.
We've improved survival.
For colon cancer. Yeah.
Phase 3.
For colon cancer.
For colon cancer, because it's there.
Yes, exactly. Because it's there inside the colon.
Yeah.
Okay. are you saying that there is still standard of care was impressed when they found that the drug is used because of something other than the regular label of it?
Yes.
Till now?
Until now.
After COVID?
Yeah,
After COVID?
yeah.
Okay.
This is the unspeakable
How
here,
many off-label
Unspeakable.
drug used in COVID and prove efficacy, starting from chloroquine phosphate? Chloroquine phosphate originally was an anti-malarial. Then it was immune suppressant. Then it used for systemic lupus. Then it used in COVID. So maybe one drug is used for 3 different.
I mean, chloroquine was used in lupus and for arthritis, and we have also how many anti-epileptic drugs are used for weight loss, right? So we do have repurposed drugs in every field of medicine. Why not in oncology? And people are not really considering it. I don't know why. Maybe because of a patent.
Yes, exactly.
Theories.
Because of labels, yes, off-label drug cannot take patency unless you change its way dramatically or changing the route of delivery. By the way, the drug delivery systems is very important field of the study. There is a lot of people is searching about this, and actually it's a connections between the bedside to the bench side. If you need to complete the pictures, you need to add the bioavailability, the pharmacokinetics, and the drug delivery system to serve on these 2 major factors affecting the drug metabolism and drug absorption in your body. By this way, I believe this may be the start of the seeing a very good result from integrative oncology in the standard of care.
One example, for example, people think that we only inhibit metabolic pathways in cancer or stimulate those we think are important to kill the cancer. But it's important that you guys understand, and I'd like you to comment on that, that sometimes we use supplements and off-label drugs actually to reduce side effects.
Yes.
For example, a diet, a ketogenic diet can reduce a lot of the side effects of chemotherapy.
Yes.
And we do have some evidence, like melatonin. We have meta-analysis of randomized clinical trials showing improved survival, less cardiotoxicity, less neurotoxicity, less fatigue. It should be prescribed to all patients in standard of care because there's more evidence for melatonin in cancer than for many drugs that are being prescribed right now.
Yes.
So why are these drugs or these supplements not being considered, since we have so many papers and even meta-analysis of randomized clinical trials? So I'd like you to comment on this supplements that can improve neuropathy, improve, for example, diarrhea from irinotecan. There are some supplements like Scutellaria bicalensis, like ginseng, like Humulus lupulus, even some other like charcoal that improve the diarrhea, which
reishi extract. Oh my God, it's improving the quality of life so much.
Yeah.
Actually, we sometimes even give the supplement not to improve the quality of life or not to treat the side effect of the integrative oncology aspect, but to increase the side effect of standard of care, or because it's showing a very promising result with this kind of chemotherapy. So actually,
synergism, right?
Again, guys, we are not against standard of care. Now I am here with your podcast saying, guys, take your chemotherapy, no problems.
Yeah.
Take your radiotherapy, but integrated, with something that may enhance its effectiveness and may increase its sensitivity and may decrease its side effect and may improve your quality of life. So again, sometimes we give supplement or even a diet because the kind of chemotherapy you got. You know that there's a huge study, it's a very good study. They use like 145 patients of stage 4 gastric carcinoma. They're taking 5-fluorouracil and they put them on methionine restricted diets before the surgery. And after performing the surgery, they found like 35 people were total remissions. Can you improve? Can you measure?
Stage 4.
Stage 4.
But this doesn't exist. No.
Can I give you the DOI number? Again, so sometimes we give the supplement or even the diet to increase the effectiveness of a specific kind of chemotherapeutic agents or even standard of care like bone marrow transplantations. Anyway, what I need to say here, dealing with supplement is a science, but actually it's art of choosing the science of choosing the supplement more than science. So yes, to understand the supplement, it's a science. to prescribe the supplement, it's art more than science.
Yeah, you have to have the science to back you up, but you need to have creativity, art, and you have
Creativity of this sense of what kind of drugs that can be act synergistically. And we don't need it up to take it like 65 different kind supplement all over the day. So you spend all your day eating supplement. So we don't need that because there is nobody can tolerate that. And again, what about the combination? What about the cocktail? And this will take me back again and again and again to drug delivery systems, to combinations of the drug, to cocktails of phytochemicals. Instead of giving 7 different kind of drug, I can combine the synergistic thing together in just 1 capsule.
Thank God in Brazil I have compound pharmacy.
You are very lucky for that.
Yeah,
and that's why I had my own lab in Egypt. I told you before. Yeah. But it was my previous job.
But now you have a new job.
Yeah, I have a new job now. Clinical research directors in Metabolic Training Institute of Health. I'm very excited that
That's
I will.
Great.
Yes.
It's amazing.
Actually, yes. Very exciting to join this wonderful group. It's leading by Dr. Nasha Winters, here. So it's non-profitable organizations, and we'll increase the drug delivery system lab. We will have our own researches regarding the formulation of this kind of drug, the effect of this kind of drug in cell culture, animal model, and even humans. We hope that we can one day make a difference.
You already do. Just they're very lucky to have you. You're lucky to be with them because they're great people. I admire them.
Thank you.
Nisha is a mentor for me too. And I'm sure you're going to be very successful. I'm sure you're going to be very successful. And just to finish, I think, can you tell us, please, what is a nanoformulation? How can we improve bioavailability of drugs? And is there a bright future ahead regarding these supplements that we would love to have inside our body, but they're stuck in the bowel?
Unfortunately, there is a lot of science is already existing, is already innovating. We are not inventing the wheel. It's already invented before. We just didn't notice it. Just Google it. Say nanoparticle formulation. Nanomedicine is one of the best revolutionary thing happened in the world in the past 50 years. And nanomedicine is not too famous. You know why? Because it decreased the area, it increased the area under the curve, was decreasing the IC50 or the effective therapeutic dose of the drug. Maybe like 10% of the drug needed to do the same effect of 100% of the native drug.
But that's great. Less side effects.
No, it's not great. It's less money.
Yeah, less
money.
Conspiracy.
No, I'm not conspiracy, but it's general, guys. Who fund the clinical trials?
Yeah, the drug companies.
Okay, good. Do you think that a drug company can fund a trial that decrease its profit margin to 1/10? And that's why the non-profit organization rule this one. Okay, back to nanotechnology. Nanotechnology is simply from its name, when we have a drug, just imagine this drug is like a cube, okay? And this cube have only 4 sides, or 8 sides, I'm sorry. I'm bad in mathematics. This cube has 8 sides, right? 8, right? Yeah. This cube has 8 sides. So
6, right?
No, 8. No,
the it's cube a square. A square? Yeah. 4.
Yes,
5,
it's 8.
6.
Okay, whatever the side is yet. 8, 6, 7. But a limited.
5, 6.
Yes, okay. This cube has 6 sides, okay? So he have a 6 chains to integrate with the enzymatic activity that work on this molecule, right?
Right.
What if I take this cube and I divide it down to 1,000 cube? How many sides you have now? Multiply 1,000 by 6,000 side. So you increase the chance of this drug to be more effective. There's a very less amount of drug, less side effect, less toxicity. By the way, there is a nanoparticles chemotherapy called doxorubicin.
Yeah.
Liposomal doxorubicin. You know why they approved this drug? Because the traditional one was retracted from the market after marketing because of the severe side effects. So the only way to take this chemotherapy is by
It's
liposomal.
amphotericin B. And also the liposomal
Amphotericin
is
is a
better.
liposomal is better. It's antifungal because it's very, very, very toxic, renal
Yeah.
toxicity. So it's only liposomal. So the only liposomal drugs approved is the drugs that cannot be taken as a native drugs. But anything with poor bioavailability, with poor pharmacokinetics or pharmacodynamics, with first pass metabolism, can bypass this by nanoparticle technology, can increase the efficacy, can increase the absorptions. We can target.
Blood-brain barrier too.
Yes,
You can get
we
there,
can
get
across
to
the blood-brain
brain.
barrier. We can target, I can control where this drug is going to go. First, it's going to the brain through submucosal delivery systems or transdermal systems, or going to your stomach, or going to the specific kind of cancers. I'll give you an examples. If you have the cancers with some kind of receptors, let's say A receptors, and this cancer express like thousands and thousands of these A receptors, and you have the ligand, which is A. If I attach this A to the drug, it will automatically went to the tumors more than the normal tissue because it have a lot of receptor of this ligand. It's called targeting.
Yeah, and this is good, guys, because it's specific. So you can use less drug and be more effective and have less side effects in normal cells while being more effective in cancer cells.
Yes, exactly.
So it's really something. And about like the specific and different kinds of vehicles, right? For example, resveratrol has 1% bioavailability, but if you do it transdermal, micronized, in Brazil they have it, it's 65% absorbed. So it's
and
much,
if you do it liposomal, it may be, curcumin. I'll give you an example of the curcumins. Curcumins, if you add piperine to the turmeric, it increasing the bioavailability of curcumin up to 10%. Okay, 10 times. Okay, remember it's 0.1% absorption, so 10 times, which is okay. It's better than nothing, right? But if you liposomal it, you increase the bioavailability of curcumins over than 100, so 186 times better.
Yeah.
If you liposomal it. So again, transdermal systems, and you know that you can formulate a chemotherapeutic drugs into a kind of local therapy, and you can implant this local therapy after you remove the tumors, and this implant slowly release the drug over time inside the microenvironments. And by the way, we did this experiment in Egypt 3 times now. We have our own non-published case series about this, and we have our own specific sector in the new lab in MTIH in Arizona. Will look inside this kind of therapy. So it's a revolution. We can change a lot of things by go back to the science, like the ketogenic diet. Remember, ketogenic diet was invented 19th century and they rediscovered after 1980 something. After
the ketogenic
Charlie.
diet has 100 years, guys. It's
Yes.
not a fashion. It's not like a fat diet. It's a centenarian diet. It's a centenarian approach to many diseases that works. It's safe, and people are trying to scare you out of it. I don't know why, because there's lots of even for cancer. I don't think the diet alone will do anything, but it actually helps. For a while, it can really help. There's actually a randomized clinical trial in women with breast cancer in which the ketogenic diet alone reduced the tumor size. So it has an effect. But imagine combining this with the supplements, with the lifestyle changes, with the sleeping, with stress control, right? Emotional stress control, with physical activity, with photodynamic therapy, sonodynamic therapy, with the standard of care. I mean, if our lifestyle is making us sick, if our metabolic choices and
changing
behavior
of this
is making us
exactly.
sick, how do you imagine, how do you figure you're going to succeed in your treatment
without changing your lifestyle?
without changing the very root causes of it?
So Janaína, I have a question for you. How you decide this cancer patient will do well in ketogenic diet or on low methionine diet, because as you know that low methionine diet is already proved to be anti-cancer treatment, and they already published in prestigious journals, New York Times and Boston's Times, even non-medical and medical journals, that low methionine diet can be the answers. Some others publications say the ketogenic diet can be the answers. How you choose between the ketogenic or low methionine?
He taught me. I must know. You can choose.
It's the same way you're choosing the supplements according to the metabolomics. Again, nothing is giving like one diet fit all.
And it changes.
There is no one supplement fit all. There is no one treatment fit all. It needs to be customized. So,
and even the same person, you can start with the ketogenic diet.
Thank you.
And something happens. The patient changes the treatment. He goes to 5-fluorouracil, and the homocysteine is up. This is his question. I have to answer. So he has high homocysteine levels. You correct methylation, the homocysteine doesn't come down, and he's using 5-fluorouracil. Lots of studies showing efficacy of low methionine diet. So change the low methionine diet, but you can't keep it so long in this setting, because not a low methionine diet, a regular one, is one that Ahmed El Saka developed for cancer together with a low carb.
I'm not the one who developed it, to be honest. But I customized
very
it
well.
to be low
better.
glycemic index to have.
Yeah, he made it much better.
Thank you.
You did.
But again,
you did.
Thank you.
But anyway, let me finish. So the same patient can be lots of patients. He's one patient before radiotherapy. During radiotherapy, he might as well benefit of high doses of boswellia and curcumin. And then after this, he might benefit of something else. And then he changes, and then now there's surgery. So surgery is a very delicate moment, lots of metastasis. He might benefit of parasympathetic modulation. He might benefit, you see, so the same patient changes over time. You can't just take a tumor and say, I'm going to give you supplements for this tumor.
And this is a difference between genotype
tumors.
and phenotype. Again.
We treat people.
Exactly.
And that's why the same cancer with the same stage doesn't respond in the same way to the same treatment. And that's why we have heterogeneous responses. And they're blaming it all on the genetics. It's not about that. This is a diabetic. This is a very anxious person that doesn't sleep. This is a person with autoimmune disease. How can you imagine they're going to respond the same way to a treatment? No, it's a completely different environment. We have to start looking at people.
Yes, thank you. Exactly.
Right?
Yeah, I'm very happy. This night, maybe like 8 hours, we talk together without have this sense of boring or tired. So.
Guys, I'll try to record one more with him before he leaves Brazil. Yeah. I promise I will. But it was very nice having you here.
I'm very happy to be with you today. I'm very happy to be in Brazil. I love Brazil. You know that I love Brazil so much. It's my second country, right? I told you, you have to tell your family you have to buy a house here so you can come every now and then and stay. Unfortunately.
But you do have a house in my place, so you don't have to worry about it.
Unfortunately, eu não falo português.
Portuguese. Now you're going to be in the States. You're going to be very close by, so you guys can come and visit us. Yes. And I think Brazil and it's going to be a good partner for you guys, because we have lots of integrative doctors here who are willing to learn.
By the way, you have a very good opportunity here, and that's why maybe this is one of the things that I love Brazil, that I wish my country would like that in the field of integrative medicine. It's being growing up so fast. Okay, you have a lot of integrative doctors. They are very passionate again toward this kind of science, and at the same time they are searching about the evidence, searching about the workshops, searching about to learn. Okay, at the same time you have amazing compounding pharmacies, okay, which solve million of problems. Yeah, we're really lucky. Okay.
We have IV drugs too. We have IV drugs too from the metabolic approach. So I do this in my clinic. Yeah, we do have some facilities in Brazil. We have high dose vitamin C. We have curcumin, melanin,
alpha-lipoic acid,
crizine, alpha-lipoic acid. Yeah, we have mistletoe. Yeah, it's great.
It's amazing.
I love being here.
Yeah, you love to be here. I envy you.
We study a lot, and we can apply what we study.
That's great.
Yeah, especially if we have like a good institute, like like
exactly.
MTIH right now, and that can back us up. And I'm actually very, very happy that you're moving to North America, because you're going to be close to us too.
Yeah, I'm very happy to.
And I think this field is changing, because patients are beginning to realize it makes sense. It makes sense, guys, you know. Diabetics have 2 to 4 times more chances to get a cancer. Obese people have 18 types of cancer related to obesity, and completely different tumors, you know, like it's obvious there's something going on.
Be aware you're opening a new discussion now. So.
Yeah, there's an elephant. Yeah, there's an elephant in the room, right? There's an elephant in the room, and patients are realizing it. So they are looking for this, for a chance to improve their treatments. So even if the oncologists, they take their time to realize that, patients won't, because they're eager. And now there's internet, and now there's YouTube, and now there's Instagram. So they find
it's better to be organized than every patient's doing it by itself, especially if this
Don't
patient
do it by
has
yourself.
no hope.
Yeah.
It will be very hard if you do it by yourself.
Don't take supplements on your own. Get a doctor, an experienced doctor, to help you go through this. Remember, you're not only one tumor. You're one person that has different phases. Some supplements you might as well take with this chemotherapy, but not with this one. Sometimes you have to take things off, then put them back. It depends, right?
Yes.
It depends. Don't do things on your own. Right? If you have a message for patients with cancer that are looking for answers
do
right
not lose
now.
hope. First of all, do not lose hope.
Look there, because they're looking at you.
Okay, guys, I know you are strong, very strong. And I ask you to not lose your hope. Search about alternative. Do not follow only one way. There is no God here. The God is up. Okay? So the doctor who treats you, he's just a person. He may be right, he may be wrong. So look for another answers. And always look for an expert to put you on the right way of this answer. So if you decide to go to integrative oncology, look who is the expert in integrative oncology. Call him, ask him. Okay? Do not do the stuff by yourself, but do not give up, and do not only give your ear to only one person, which is a standard of care. And at the end of the day, you will make it.
And take care with supplements. Don't take all of them.
By the way, we will all die, right?
Yeah.
At the end of the day, there is no mortality here. We will not all die. I'd rather die with a good quality of life rather than extend my life with a very bad quality of life. And by the way, there is nothing called extension of life. You will live your life a bit, and you have the choice even to leave it with a good quality of life or the bad quality of life. That's it. Thank you very, very much to be with you today.
Thank you.
I hope we can repeat it again.
Yes, we will.
Thank you.
Bye-bye, guys.
Bye-bye.
Thank you.